Okay, 34th day, March 12th, Thursday. It's pretty short. Scoliosis, Maggie book, and Scheuermann disease, the Kistner book. I'm going to start with the Kistner book here. There's only 3 pages, and it's like sporadic. It's not any like real smooth reading. But I'll start here.
Scheuermann's disease. Scheuermann's disease is a rare congenital and autodegenerative weakening of the vertebral end plates, typically seen at T10L2.149. The nucleus pulposus can protrude vertically into the vertebral end plate, which can lead to a bony necrosis or Schmall's nodes. Scheuermann's disease may also be caused by insufficient blood supply to the growing bone. This pathology is usually seen in the second decade of life and may be diagnosed as growing pains. Intervention should be related to presenting signs with the caution to minimize compressive forces on the vertebrae.
Okay, that's it for that page. And then it moves to 473. Kind of a weird day, I guess.
Scheuermann's disease. This pathology is similar to Npte, except the nucleus pulposus migrates either superior or inferior versus posterior or posterolateral. Scheuermann's disease is the result of a weakened vertebral end plate. This weakness causes a crack and a breakdown in the weight-bearing ability of the vertebra. The nucleus pulposus then travels to the path of least resistance. Typically, patients with Scheuermann's disease do not have any radicular symptoms as the nerve roots are not involved. Intervention: segmental and global stabilization exercises, stretching of tight muscles, posture education, joint manipulation may be used either for pain modulation or to improve ROM. 125. However, use caution with high velocity techniques. Scoliosis.
So, this little bit here and that little bit there. That's pretty much it for Scheuermann's disease. Okay. Making sure. It's kind of weird. Weird day. So we will move on to the Maggie book. Please. So moving on to the Maggie book, starting with page 515 down here where it says scoliosis.
This is a deformity in which there are one or more lateral curvatures of the lumbar or thoracic spine. It is this spinal deformity that was suffered by the Hunchback of Notre Dame in the cervical spine. The condition is called torticollis. The curvature may occur in the thoracic spine alone, in the thoracolumbar area, or in the lumbar spine alone. Figure 812. Scoliosis may be non-structural, that is, relatively easily correctable once the cause is determined, or structural. Poor posture, hysteria, nerve root irritation, inflammation in the spine area, leg length discrepancy, or hip contracture can cause non-structural scoliosis. Structural changes may be genetic, idiopathic, or caused by some congenital problem, such as overwebbed vertebra, hemivertebra, or failure of vertebral segmentation. In other words, there is a structural change in the bone. A normal flexibility of the spine is lost. 11. A number of curve patterns may be present with scoliosis. Figure 813.11. The curve patterns are designated according to the level of the apex of the curve. Table 8.3. A right thoracic curve has a convexity toward the right, and the apex of the curve is in the thoracic spine. With the cervical scoliosis, or torticollis, the apex is between C1 and C6. For a cervicothoracic curve, the apex is at C7 or T1. For a thoracic curve, the apex is between T2 and T11. The thoracolumbar curve has its apex at T12 or L1. The lumbar curve has an apex between L2 and L4, and a lumbosacral scoliosis has an apex at L5 or S1. The involvement of the thoracic spine results in a very poor cosmetic appearance or greater visual defect as a result of deformation of the ribs along with the spine. The deformity can vary from a mild rib hump to a severe rotation of the vertebrae, causing a rib deformity called a razorback spine. With the structural scoliosis, the vertebral bodies rotate to the convexity of the curve and become distorted. 12. If the thoracic spine is involved, this rotation causes the ribs on the convex side of the curve to push posteriorly, causing a rib hump and narrowing the thoracic cage on the convex side. As the vertebral body rotates to the convex side of the curve, the spinous process deviates toward the concave side. The ribs on the concave side move anteriorly, causing a hollow and a widening of the thoracic cage on the concave side. Figure 8.14. Lateral deviation may be more evident if the examined uses are plumb bob, plumb line, from the C7 spinous process or external occipital protuberance. Figure 8.15. The examiner should note whether the ribs are symmetric and whether the rib contours are normal and equal on the two sides. In idiopathic scoliosis, the rib contours are not normal, and there is asymmetry of the ribs. Muscle spasm resulting from injury may also be evident. The bony and soft tissue contour should be observed for equality on both sides or for any noticeable difference. The examiner should note whether the patient sits up properly with the normal spinal curves present. Figure 8.16. A. Whether the tip of the ear, tip of the acromion process, and high point of the iliac crest are in a straight line as they should be, and whether the patient sits in a slumped position, that is, sag sitting, as in figure 8.16. B. The skin should be observed for any abnormality or scars. Figure 8.17. If there are scars, are they a result of surgery or trauma? Are they new or old scars? If from surgery, what was the purpose of the surgery? Breathing as part of the observation. The examiner should note the patient's breathing pattern. Children tend to breathe abdominally, whereas women tend to do upper thoracic breathing. Men tend to be upper and lower thoracic breathers. In the aged, breathing tends to be in the lower thoracic and abdominal regions. Figure 8.18. The examiner should note the quality of the respiratory movements as well as the rate, rhythm, and effort required to inhale and exhale. The examiner should also note whether the patient is using the primary muscles of respiration and or the accessory muscles of respiration, because this will help indicate the ease of the patient's breathing. Table 8.4. In addition, the presence of any coughing or noisy or abnormal breathing pattern should be noted, because the chest wall movement that occurs during breathing displaces the pleural surfaces, thoracic muscles, nerve, and ribs. Pain is accentuated by breathing and coughing if any one of these structures is injured. Chest deformities in addition to rib movements during breathing. The examiner should note the presence of any chest deformities. The more common deformities are shown in figure 8.19 and are listed below. 1. With a pigeon chest, pectus carinatum, deformity, the sternum projects forward and downward like the heel of a boot, increasing the anteroposterior dimension of the chest. This congenital deformity impairs the effectiveness of breathing by restricting ventilation volume 2. The funny chest, pectus excavatum, is a congenital deformity that results from the sternums being pushed posteriorly by an overgrowth of the ribs. 13. The anteroposterior dimension of the chest is decreased, and the heart may be displaced. On inspiration, this deformity causes a depression of the sternum that affects respiration and may result in kyphosis. 3. With the barrel chest deformity, the sternum projects forward and upward so that the anteroposterior diameter is increased. It is seen in pathological conditions, such as emphysema.
Alrighty then. What a weird place to put breathing stuff. So, going back to the PowerPoint, so that read to us everything that was on there. I'm going to pause. Okay, so my reader just read these pages. Oh, what I just read. Scheuermann's disease is the most common structural kyphosis in adolescents that can occur in adults. Its etiology is unknown. I didn't even see that. Anyway, so those are the 4 pages that were included in the reading here. Listener Maggie and the reader just got done reading it. And so I went off camera to do a little bit of more in-depth studying. So I'm going to record it so when I come back to it, I won't have to redo the in-depth studying. So the curvature may occur in the thoracic spine alone, in the thoracolumbar area, or in the lumbar spine alone. See figure 8.12. So A says postural deformity caused by idiopathic thoracolumbar scoliosis. That means the thoracic and the lumbar are involved. B is asymmetry of posture of thorax accentuated with patient flexed. Note the hump on the right and the hollow on the left. Scoliosis may be non-structural, relatively easily correctable once the cause is determined, or structural. For posture, hysteria, nerve root irritation, inflammation in the spine area, leg length discrepancy, or hip contracture can cause non-structural scoliosis. Structural changes may be genetic, idiopathic, or caused by some congenital problems such as wedge vertebrae, hemivertebra, or failure of vertebral segmentation. In other words, there's a structural change in the bone and normal flexibility of the spine is lost. So here are examples of scoliosis curve patterns. The top left, we have the right thoracic curve, the right thoracolumbar curve, left lumbar curve, right thoracic and left lumbar curve, double major curve. The curve patterns are designated according to the level of the apex of the curve. See table 8.3. Only thing, let's see, in the next slides I did not cover would be this one and this one. Because these here, yeah, this one. Because this here is going to be in the next slide. And these are also going to be in the next slide. Because they are addressed here. Right thoracic curve, thoracolumbar curve here, lumbar curve, and then with a cervical scoliosis or torticollis, the apex is between C1 and C6. With the lumbosacral scoliosis, the apex is going to be at L5 or S1. Those are the ones. And cervicothoracic curve, the apex will be at C7 or T1. Did I say that one? So, right thoracic curve. The convexity is towards the right. So, right thoracic curve. So, you name the curve by the direction that it's curved. The convexity is towards the right. So, it's a right thoracic curve. Apex of the curve is in the thoracic spine. Thoracic curve apex is between T2 and T11. T2 and T11. Table A3, curve patterns and prognosis in idiopathic scoliosis. So we're looking at the curve pattern, primary thoracic curve. The incidence is 22.1%. Average age curve noted is around 11 years old. Average age curve is stabilized, is around 16 years old. The extent of the curve is at T6 to T11. So the extent of the curve, like, one, two, yep, yep. This part of the curve right here, the extent of the curve is T6 to T11. Apex of the curve is right in the middle of that, T8 or T9. Rotation is extreme, convexity usually to the right. Rotation is extreme at the apex. Average angular value at maturity degrees in standing is 81.4. And in supine is 73.8. I can't imagine needing to know those numbers for the test. Prognosis. This is the worst prognosis. Primary thoracic progresses more rapidly, becomes more severe, and produces greater clinical deformity than any other pattern. 5 years of active growth, during which curve could increase. Okay, moving on to the left lumbar curve. Apex is between L2 and L4. L2 and L4. The incidence percentage is 23.6. Average age curve is noted is around 13.5. Average age curve is stabilized 14.5. Extent of curve is from T11 to L3. The extent of the curve, T11 to L3, and the apex of the curve is right in the middle, usually L1, L2. Average angular value at maturity in degrees and standing 36.8, supine 29.1. Prognosis, most benign and least deforming of all idiopathic curves. So the primary lumbar curve pattern is the least deforming of all idiopathic curves. The previous slide showed us that the thoracic is the worst, progresses more rapidly. The thoracic is the worst, lumbar is the least. Now we're going to look at a combination. The thoracolumbar curve has its apex at T12 or L1, so right where the lumbar, the thoracic and the lumbar come together, which we know is very weak. The conjunction of T12 to L1 is a very weak connection based on the design or shape of the vertebrae. Right thoracolumbar curve. Incidence, 16%. Average age curve is noted as 14. Average age curve is stabilized, 16. The extent of the curve is T6 or T7. T6 or T7 to L1. So T6 to L1, T7 to L1, or L1, L2. The apex of the curve is T11 or L2. T11 or L2. The prognosis is not severely deforming, intermediate between thoracic and lumbar curves. Not the worst, but not the best. combination. So now we're to the right thoracic and left lumbar curve, which is a double major curve. Ooh, yeah, S shape. That's actually what they call it. So again, the right thoracic curve is convexity toward the right. Apex of the curve is in the thoracic spine. The thoracic curve apex is between T2 and T11. The lumbar curve, the apex is between L2 and L4. Oops, I didn't change that. Oh no! Crud. Please hold. Okay, so I have to go fix that. So, combined thoracic and lumbar curve, the incidence is pretty high. Look at that, 37%. Average age curve is noted is 12, around 12 years old. Average age curve is stabilized at 15 and a half. So a little after 12, stabilized 15 and a half. The extent of the curve, thoracic T6 to T10, lumbar T11 to L4. The apex of the curve, thoracic is T7 or T8, and the lumbar is L2. They're kind of somewhere in the middle of both of those spinal regions. Prognosis is good. Body usually will align curves, even if severe, tend to compensate each other. High percentage of very severe scoliosis if onset before age of 10 years old. So here are all the curve patterns and prognosis of the idiopathic scoliosis altogether. So incidence, which is the highest, combined thoracic and lumbar is the highest at 37%. The average age curve is noted anywhere between 11 to 15 years old, 11 to 15. So primary thoracic being noted first as one ages. Combined thoracic lumbar by 12 years old. Primary lumbar around 13. Thoracolumbar around 14. And cervical thoracic around 15. Average curve is stabilized, is right around 15, 16 years old. So it looks like the lumbar stabilizes fairly quickly. It's noted and then stabilized fairly quickly. There's almost a 2-year gap here between the thoracolumbar. A 3-year gap here, thoracic and lumbar, probably because it's more, you got combined two curves. You remember, it's like a double major curve. It's a double major curve, so it's going to stabilize, take longer to stabilize. However, the primary thoracic, wow, it's the worst prognosis. It's noted the earliest, and it stabilizes almost last with a 5-year gap. So the thoracic scoliosis is not good. The combined thoracic and lumbar is not too bad. Okay, but the primary lumbar is the best. Didn't really talk that much about cervical thoracic because we didn't have a picture of it. But the apex of the curve is right around T3. The extent of the curve is T7 or T1 to T4 or T5. You're forming unslightly Poorly disguised because of high shoulder, elevated scapula, and deformed thoracic cage. With a structural scoliosis, the vertebrae bodies rotate to the convexity of the curve and become distorted. Okay, so there's a concave side of the curve, convex side of the curve. Spinous process deviated towards concave side. Vertebral body distorted towards convex side. Interesting. Rib pushed posteriorly and thoracic cage is narrowed, a hump. So this rib is pushed back and the thoracic cage here is narrowed. So you have a hump on the convex side. So let's see. I need a picture. So need a picture. Let's see. Such a visual learner. If this will help. Okay. So the spinous process is deviated towards the concave side. So this is convex, right? And this is concave, right? So the spinous process would be deviated towards this way. Towards the there. Spinous process will be deviated towards the concave side. Rib is pushed posteriorly rib is pushed posteriorly and the thoracic cage is narrowed. Ouch. Vertebral body distorted towards convex side. Ouch. Direction and rotation. The thoracic cage on this side is wider, more hollow. Wow. This was fun. Let's turn this. Turn it. Wish we could put it on top of there. You know what I mean? And you actually need to flip it. And I don't know how to do that, so I knew there's a way to do it. Okay, anyway, so there you go. Moving on. Lateral deviation may be more prominent if the examiner uses a plumb line. Ooh, look at that. Yep. From C7 spinous process or external occipital protuberance. Right thoracic idiopathic scoliosis is what we're looking at. So let's go up here and get a picture. See, let's come down. Don't do that. Don't do that. Nope. Okay, so let's go ahead and duplicate slide, take that and delete it. Oops. We want to delete the whole thing. Let's paste that picture there. There we go. That's what we're looking at. I want to see inside the body. Yep, that's what it looks like. Right thoracic idiopathic scoliosis. Left shoulder is lower. Okay. Low left shoulder. Okay. Right scapula is more prominent. Went there. Okay. Note decreased distance between right arm and thorax right here. That's what it wants. Right here. And thorax with shift of the thorax to the right. There's a shift towards the right. Oh, that's not what we want, is it? Okay. The left iliac crest appears to be higher, but big letter, but this results from the shift of the thorax with fullness on the right and elimination of the waistline. The high hip is only apparent, not real. Okay? The high hip is only apparent. It is not real. Okay. Not real. Plumb line is drawn from prominent vertebrae of C7. Measures the decomposition of the thorax over the pelvis. Distance from the vertical plumb line to the gluteal cleft is measured in centimeters and is recorded along the direction of deviation. If there is a cervical or cervical thoracic curve, plumb should fall from the occipital protuberance. There you go. Right thoracic. Now, I found us a cool video.
Scoliosis is an abnormal curvature of the spine that, if left untreated, can lead to medical complications. In order to understand scoliosis better, let's first take a look at a healthy spine. Small bones called vertebrae align in a series to compose the spine. Ligaments and muscles connected to the spine provide stability while allowing movement. A healthy spine has natural front-to-back curves. The curve in the neck area is called the cervical spine. The second curve forms the thoracic spine, located in the upper back. And the third curve forms the lumbar spine, located in the lower back. A healthy spine appears straight from a front or back view. Scoliosis causes an abnormal side-to-side curve of the spine. This affects the structure and posture of the rest of the body. One hip or one shoulder may appear higher than the other. The shoulder blades may stick out, and the body may lean to one side. Scoliosis is a progressive condition, meaning that it can get worse over time. If left untreated, a severe curvature can form, causing the vertebrae to rotate and move even further out of position. This can make it difficult to breathe, or cause pressure on the spinal cord and nerves, causing pain and fatigue. So what causes scoliosis? Some people are born with malformed vertebrae, unequal leg lengths, or fused ribs that cause congenital, meaning born with, scoliosis. Neuromuscular conditions such as cerebral palsy, muscular dystrophy, spina bifida, and polio can also lead to scoliosis. In adults, scoliosis may develop because of degenerative changes in the spine, including osteoporosis, a bone-weakening disease, and arthritis. In most cases, the cause of scoliosis is unknown, and this is termed idiopathic scoliosis. Mild spine curvature usually do not require treatment, but are monitored. Back bracing may be used to treat curvatures that are more significant for children that are still growing. Back braces use pressure to strengthen the spine. Physical therapy can help to strengthen the back and improve balance while sitting, standing, and walking. Occupational therapy can help improve independence with daily activities, such as dressing. Therapists can custom order seating systems that provide support and help maintain posture. Surgery is usually required for spine curvature that are significant because of the high risk of medical complications. Spinal fusion surgery is used to correct the curve in the spine and secure the vertebrae together. Children are screened for scoliosis in most school systems, and adults are screened for osteoporosis as they age. Regular monitoring and intervention may help scoliosis from becoming worse and allow the greatest amount of independent activity.
Well, that was pretty elementary. Definitely not on a doctor level for sure. Ribs are not equal heights. Well, let me pause this. I'm going to go searching for a better video. Okay, I could not find a video, but I found another picture that I liked in our Kinesiology of the Musculoskeletal System ebook, the Newman book. I love that book. But this is a 12-year-old, and she has a thoracolumbar scoliosis. So thoracolumbar curve, apex at T12 or L1. It's the opposite of right. Hers is left. Okay, so I want you to notice that the curve right here, that is going to determine the arm position. So if you notice that the patient's arm is really close to their side, and then they have a gap on this side, you know that that curve is towards the side where the arm is closest to the body. More of a gap, that's going to be your concave side with the arm close to the body. That's going to be your convex side. And then your hump is going to be on the convex side, like this. 12 years old, you can see thoracolumbar was around noted 14. So hers is pretty notable at 14. And this is post-operatively, like pictures. Pretty good. Still see some deformities here, but the curvature is definitely better. Most definitely better. Okay, let me go see what else I can find. Please hold. Okay, I didn't find too much. But in the Kinesiology of the Musculoskeletal System ebook, I did find a picture of the Cobb angle, which measures the degree of lateral bend in a spinal curvature associated with scoliosis. In this example, the thoracic spine shows a Cobb angle of 75 degrees with an apex of the curve at the T4, T5 junction. The Cobb angle is measured from a radiograph showing an anterior posterior view. And then from the Netter's Clinical Anatomy ebook, I found the same, pretty much the same picture we had before. Right here, or explain that. Section through scoliotic vertebrae, decrease vertebral height, and disc thickness on the concave side. So decrease vertebral height and disc thickness on the concave side. And there's the plumb line. And okay, I'm going to end today's video on focusing on Scheuermann's disease, kyphosis. So let's see. Oops.
Scheuermann's disease. Scheuermann's disease is a rare congenital and autodegenerative weakening of the vertebral end plates, typically seen at
Okay, let's try that again. Had a phone call, it messed up my thing.
Scheuermann's disease. Scheuermann's disease is a rare congenital and autodegenerative weakening of the vertebral end plates, typically seen at T10L2.149. A nucleus pulposus can protrude vertically into the vertebral end plate, which can lead to a bony necrosis or Schmall's nodes. Scheuermann's disease may also be caused by insufficient blood supply to the growing bone. This pathology is usually seen in the second decade of life and may be diagnosed as growing pains. Intervention should be related to presenting signs with the caution to minimize compressive forces on the vertebrae. Scheuermann's disease. This pathology is similar to Npte except the nucleus pulposus migrates either superior or inferior versus posterior or posterolateral. Scheuermann's disease is the result of a weakened vertebral end plate. This weakness causes a crack and a breakdown in the weight-bearing ability of the vertebra. The nucleus pulposus then travels to the path of least resistance. Typically, patients with Scheuermann's disease do not have any radicular symptoms as the nerve roots are not involved. Intervention: segmental and global stabilization exercises, stretching of tight muscles, posture education, joint manipulation may be used either for pain modulation or to improve ROM. 125. However, use caution with high-velocity techniques. Scoliosis. Scoliosis is a deformity in which there are one or more lateral curvatures of the lumbar. Scheuermann's disease is a rare congenital and autodegenerative weakening of the vertebral end plates, typically seen at T10L2.149. A nucleus pulposus can protrude vertically into the vertebral end plate, which can lead to a bony necrosis or Schmall's nodes. Scheuermann's disease may also be caused by insufficient blood supply to the growing bone. This pathology is usually seen in the second decade of life and may be diagnosed as growing pains. Intervention should be related to presenting signs with the caution to minimize compressive forces on the vertebrae. Scheuermann's disease. This pathology is similar to Npte except the nucleus pulposus migrates either superior or inferior versus posterior or posterolateral. Scheuermann's disease is the result of a weakened vertebral end plate. This weakness causes a crack and a breakdown in the weight-bearing ability of the vertebra. The nucleus pulposus then travels to the path of least resistance. Typically, Patients with Scheuermann's disease do not have any radicular symptoms as the nerve roots are not involved. Intervention: segmental and global stabilization exercises, stretching of tight muscles, posture education, joint manipulation may be used either for pain modulation or to improve ROM. 125. However, use caution with high-velocity techniques. Kyphoscoliosis overview and etiologic factors. Scheuermann disease, juvenile kyphosis, vertebral epiphysitis, is a structural deformity classically characterized by anterior wedging of 5 degrees or more of 3 adjacent thoracic bodies affecting adolescents between the ages of 12 and 16 years. Scheuermann disease is the most common cause of structural kyphosis in adolescents, with an incidence of between 4% and 8%. 243. The mode of inheritance is likely autosomal dominant, but the etiologic factors and pathogenesis of this excessive kyphosis remain unknown. Scheuermann originally proposed that vascular disturbance of the vertebral epiphysis during periods of rapid growth was the underlying cause. However, this has not been subsequently supported. Scheuermann disease also has been associated with increased levels of growth hormone, and individuals with this disease are frequently taller than average. In the aging population, kyphoscoliosis, adult round back, is more likely to develop as a result of poor posture, degeneration of the intervertebral discs, vertebral compression fractures, or osteoporotic collapse of the vertebrae. In addition, endocrine disorders, for example, hyperparathyroidism, Cushing disease, arthritis, Paget disease, metastatic tumor, or tuberculosis can also result in kyphosis. Clinical manifestations: adolescent kyphosis is usually asymptomatic despite the prominent vertebral spinous processes. Some adolescents experience mild pain at the apex of the curvature in addition to fatigue and tenderness or stiffness in the involved area or along the entire spine. The pectoral, hamstring, and hip flexor muscles are often tight, producing a crouched posture with anterior pelvic tilt and lumbar lordosis. Signs and symptoms associated with adult kyphosis are similar to those of the adolescent form, but rarely produce local tenderness unless caused by vertebral compression fractures. In both adolescent kyphoscoliosis, Scheuermann disease, and adult kyphosis, the vertebrae are wedged anteriorly and disc lesions called Scheuermann nodes develop. Scheuermann nodes are localized extrusions of the nuclear material through the cartilage plates and into the spongy bone of the vertebral bodies. The cancellous bone reacts by encapsulating the herniated tissue within a wall of fibrous tissue and bone, producing the Scheuermann node. Medical management: diagnosis: adolescents may be referred for medical evaluation as a result of school screening, or they may present because of concerns over posture and appearance. Adults more commonly present because of increased pain. Diagnosis is based on clinical examination and confirmed by radiographic findings, including Scheuermann nodes, endplate narrowing, and irregular endplates. Treatment: indications for treatment remain controversial because the true natural history of this disease has not been clearly defined. Presently, the choice of treatment in Scheuermann kyphosis is based on the severity and progression of the curve, the age of the individual, and the symptomatology present. Bracing appears to be very effective if the diagnosis is made early in adolescents who have not reached skeletal maturity and have curves of less than 50 to 65 degrees, where a correction of more than 15 degrees can be achieved in the brace. 137. 243. Surgical management is warranted in those with more severe curves and in adults who continue to show progression of the curve or who have progressive neurologic symptoms or unmanageable pain.
Okay, so I got all of that from, pretty sure it was the pathology book. Pretty sure. Pathology. What are these nodes that they keep talking about? Where is that? You know, I'm curious. Are you curious? Look, what is this node that they're talking about? Commonly observed in routine radiographs. Herniation of the nucleus propulses into the adjacent end plate. Forms a defect in the upper and lower surface of the involved vertebrae. Nodes tend to occur near the central or posterior axis. Common in radiographic feature of Scheuermann's disease. Chondrodysplasia, such as multiple esophageal dysplasia. Ooh. There's a node. The node's there. The node's there. Localized defect in the vertebral end plate. Well-defined herniation pit in the vertebral body. Very interesting. This picture. Yeah, disc. End plate. Normal disc. There's the node. There we go. Now we know what a node is. I love it. All right, that's it for this date. We're done. We are done.